Hi there and welcome back. We're continuing our discussions of pharmacokinetics, which includes the absorption, distribution, metabolism, and excretion of drugs. And right now we'll be talking about the distribution of drugs. We finished our last video as the orally consumed medication was going down to the microvilli of the small intestine and being absorbed in the microvilli. And from there it's going to go into the hepatic portal venous system. We'll discuss more of that when we talk about metabolism, but it's important to note that right now. Orally consumed medications will go through what we call the hepatic first pass mechanism, or in other words, go through the liver before it's distributed to other tissues or any other part of the body. Oftentimes, before the drug even gets to the liver, it acts as a protein carrier molecule. Many of our drugs are carried by proteins such as albumin or the globulins, especially if the drug is highly lipophilic, or in other words, fat soluble. Each drug will have a different affinity to that protein carrier molecule, and as such, each drug will have a certain percentage that is normally bound to proteins. And importantly, it's only the unbound portion of the drug that can be metabolized, and it's only the unbound portion of the drug that can exert its effect. And as you hear that, you may be thinking, well, if 80% is bound to the proteins, then the 80% is going to be ineffective, right? Because, as you just said, the unbound portion of the drug is the only portion that can be metabolized or exert its effect. But you have to remember that this binding is going to establish what's called a chemical equilibrium. So for instance, if the drug is in the liver and 80% is bound to the proteins and 20% is free, the 20% that's free is going to go into the hepatocytes to be metabolized. But what does that do to the percentage that is bound in the blood? Well, that raises the percentage, doesn't it? But that chemical equilibrium must be reestablished at that point. So some of the drug is going to disassociate from the protein carriers right then. And in the end, all of the medication that's reversibly bound to the proteins will eventually disassociate from that protein carrier and be available to perform its actions or be metabolized. A highly bound drug, however, may take longer for that to happen. The other important concept about distribution is the way in which the drug is distributed among the four major body compartments: the blood, the fat, the extracellular fluid, and the intracellular fluid. And as a drug enters a compartment, for instance the blood, the unbound drug begins to distribute into other body compartments, and once again establishing an equilibrium between those body compartments until the drug reaches equilibrium throughout the body. In the quiz on this lesson, we're going to take a couple clinical scenarios that are going to reinforce these concepts. We'll see you there. We were just talking about the fact that many of our medications bind to protein carrier molecules in order to get distributed around the body. And we're saying that only the unbound portion of the drug is going to exert its effect. Albumin and globulins are the proteins that are most frequently used to carry those drugs, and which protein carries a particular drug depends on the properties of the drug itself. So for instance, one drug that is highly acidic may be carried by albumin and another drug may be carried by the globulins. But it's important to realize that we don't have a limitless capacity to carry drugs on proteins. The binding spots on our proteins can be completely saturated, meaning that despite the fact that a drug is normally, for instance, 80% bound to proteins, there may be certain instances in which there's not enough free proteins to carry that drug. Using that information, let's take a clinical scenario. Mrs. Ling is stabilized on a medication, let's call that medication A, that is highly bound to albumin. She is then prescribed an additional new medication, let's call that medication B, that is also highly bound to albumin, but it's got a much stronger affinity to albumin. What do you suspect would happen? 1, there would be no change in the effect of drug A, or 2, drug B, the one that binds more strongly to albumin, may knock a lot of drug A off the albumin, leaving more of the unbound drug A to possibly exert toxic effects. And you were correct if you said 2, drug B may knock a lot of drug A off the albumin binding sites, leaving more of drug A free. And if there's more of drug A free, then there's a greater potential of adverse and toxic effects of that drug. While the potential for this type of reaction to occur is really overestimated in pharmacology books, it's one of the reasons that 2 medications are oftentimes contraindicated together. It can also contribute to adverse reactions in people who are deficient in proteins. For instance, in liver disease, where the person isn't making adequate proteins, and in some types of kidney disease, where the person is losing their proteins. And to be clear, most of the problems associated with drug toxicity in people with liver disease comes from the fact that the liver metabolizes most drugs. And in liver disease, the liver is simply not doing its job very well. But the low protein levels still seem to play some role in the toxicity of drugs in liver failure. With that, we're going to move into the next process of pharmacokinetics and get a much better picture of the role of the liver in the metabolism of drugs.